Okay. So I know some MDs might have the incorrect link, and so we're working on that behind the scenes, but we'll just kind of get started in the meantime. So 1 second. All right. So welcome everyone. I am Naomi Damerville. I'm a psychologist and assistant professor at Mount Sinai Hospital on the Icahn School of Medicine. I feel that many of you are from Sinai. If you're outside of Sinai, welcome. Hope you enjoy our talk. So on behalf of Mount Sinai, I'd like to thank you guys for joining us for today's Just Talks lecture. So Just Talks, the Equity and Social Justice and Mental Health lecture series is brought to you by the Health Systems Department of Psychiatry Steering Committee. So this year's theme centers on the relationship between psychiatry, mental health, and social determinants of health. And the Just Talks lectures and discussions that we'll have after today's talk really hopes to facilitate important and complex conversations, discussions that tackle the challenges that are faced by our patients and our communities on individual and structural levels. So I think today's topic will be really relevant. So before I introduce today's speaker, I just want to give a quick note about ways to collect your continuing education credits for the various disciplines. So as a reminder, CMEs and CEs are available only to Mount Sinai affiliated physicians, nurses, and social workers only. And information about how to collect those CMEs, CEs will be put in the chat throughout the course of the talk. CEs are available to all psychology, PhD, PsyD attendees, and that link will be put in the chat towards the end of the talk, so around 11:45 or so. And that link will be available for about an hour after the chat, so the talk, so about until 1 p.m. And if you have any questions or concerns about that, please reach out to the people that are going to be identified for those disciplines. All right, so with that said, I'm very honored to introduce today's speaker, Brianna Suslovic. So Brianna Suslovic is a social worker. She's a forensic social worker, social welfare policy analyst, organizational consultant, and educator who studies jail to community transitions and works to bridge community mental health, criminal legal systems, health policy, and psychoanalytic theory. So Ms. Suslovic teaches and engages in research scholarship at the University of Chicago's Crown Family School of Social Work, Policy, and Practice. And she also serves as the Robert Wood Johnson Health Policy Research Scholar, a Mansueto Institute Urban Doctoral Fellow, and a Posen Center Mass Incarceration Working Group Fellow. Ms. Suslovic has years of direct experience working in and around New York City and Chicago's criminal legal systems and provides social justice consultation to organizations. So today's talk will focus on disparities that are generated and exacerbated by the prison industrial complex. She's aiming to review sort of tools to help increase literacy around these systems and give us clarity and guidance on the role of healthcare providers and community providers in assisting in the reentry process. So hopefully we'll learn how to kind of create better working alliances with patients and clients who are impacted by criminal systems and review some referrals and resources to help people in the New York City area. So with that said, Ms. Brianna Suslovic.
Hi, everyone. I really appreciate you all joining us this morning. I'm going to share my screen. And I mentioned that I will have plenty of time, hopefully at the end of my talk, for questions. So please feel free to use the Q&A function. You're also welcome to put questions in the chat. I think we'll start at the end of my talk with the questions in the Q&A. And if there's time, we'll get to the chat. But generally speaking, I love as specific or as broad questions as you all have. I think it'll be really helpful for me to sort of mold our conversation after the talk to the context that you all are coming from. And so I really appreciate you engaging with me and thinking through some of the components of collaborative practice with folks who are impacted by carceral systems. So I wanted to start just by reviewing a bit of an agenda for today's talk. Today's agenda will cover a number of macro and micro level considerations for working with clients who are impacted by carceral systems. The goal is to familiarize providers in hospital and community contexts with some of the core components of carceral systems, the ways that they show up in the lives of our patients, and the ways that they intersect with the healthcare providing systems that we might be a part of. We'll talk a little bit about incarceration and criminal legal involvement as drivers of health disparities. We'll review something called the sequential intercept model. We'll make some connections and distinctions between jail and prison and the reentry processes for each. And we'll talk a little bit about rapport building and forming a working alliance with system impacted clients before we transition to talk a little bit about how abolition has been taken up as an issue relevant to a number of public health scholars as of late. I'll review some New York City-based referrals and resources that I've made use of over the course of my time practicing in New York. And then we'll definitely have time for a Q&A at the end that hopefully brings together some of the concepts that we'll be talking about today. So I just wanted to start with a little bit of context about where I'm coming from. As we discussed, I'm currently working toward a PhD in social welfare policy at the University of Chicago. I come to this work with a background in social work, particularly in forensic social work. I have experience working for a public defender's office and a reentry-focused community mental health clinic, both in New York City. My training is pretty psychodynamic. I come from a social work program that was very oriented toward introducing psychoanalytic theories as the foundation to a lot of clinical practice. And so that shows up a lot in my work. But I'm also really interested in studying particularly the transition period between jail to community, focusing on New York City, but thinking about it in terms of also other major cities and the different infrastructures and resources available across different contexts. And I'm really interested in thinking about abolitionist theories and practices as tools that are useful for our clinical education and also tools that we can try to make use of in our micro interventions and practice. So I'm currently based in Chicago. I'm a licensed social worker here, but most of my practice roots are in New York. So as we get into our conversation today, I want to start with this note on language from a really amazing collective of currently and formerly incarcerated scholars who are affiliated with the University of California at Berkeley. They're called the Underground Scholars Initiative, and they are a mix of individuals who have been incarcerated or are currently incarcerated, thinking about, I think, the importance of having their perspectives in processes of research around different carceral and criminal legal systems. So they write that language is not merely descriptive, it is creative. And I think that this is an important place to start our conversation because the language that we use obviously impacts the way that our clients and patients are able to engage with us. It's really, I think, relevant in the context of any intersection with the criminal legal system, given its roots in chattel slavery, to be thinking about the ways in which people are humanized or dehumanized by the systems themselves, but also by the language that's frequently deployed in the context of those systems. And so I want to take a moment to review some terms that are suggested by the Underground Scholars Initiative as language that I think can be a helpful starting point. And I'll offer it with the caveat that's also offered by individuals from this collective, which is that it's also always best to follow the lead of your patient or client. And so if they're using self-descriptors that don't align with these, I think it's helpful to be able to mirror that back to them and also to express curiosity about where those terms that they're using to describe themselves are coming from. So you'll see here that I've highlighted language around how to describe someone who's currently incarcerated, someone who's formerly incarcerated, and also offered a definition from this collective about what system impacted means. Incarcerated person is a helpful phrase to refer to anyone who's currently incarcerated. I think it's a helpful phrase largely because it doesn't make a claim about someone's guilt or innocence. I think words like convict or inmate or prisoner tend to attach permanent identity to a status that is really just reflective of a period in someone's life, a period in which they are in contact with or under the supervision or detention or control of carceral systems. And I think that it's really relevant to be able to recognize incarceration as a process that occurs in a bunch of different ways in our country. So to use a term that's relatively broad, like incarcerated person, I think is a helpful pathway to also not over-determining what the experiences of a patient or client might be. Similarly, formerly incarcerated is much better, in my opinion, as a term that really helps to explain all of the different contexts in which someone may have been incarcerated, including things like juvenile detention centers, local jails, also immigration detention centers. A lot of umbrella terminology, I think, is what I'll be using in my language today, and I would encourage you to also use as well. And then finally, system impacted is a useful phrase to talk about the very broad reach of the prison industrial complex or the carceral system, recognizing that incarceration not only impacts individuals who are incarcerated, but also impacts family members of people who are incarcerated, family systems and communities. There's a way in which the removal of individuals from their communities or from their homes by the state obviously has an impact beyond the scope of just an individual. And so recognizing that system impacted is language that encompasses a broader scope, I think can be really helpful when we're thinking about how we describe the experiences of individuals, but also families and communities. So I've already used the term carceral system a few times during my talk. I want to pause and recognize that I think most folks are familiar with criminal justice system as the terminology. But I think that generally speaking, I've been given a lot of really generative feedback from patients, clients, and collaborators about the ways in which criminal justice system does not reflect the ways in which individuals entangled in the system might be defining justice. And so I think that it's helpful to use a phrase like carceral system, largely because it opens up the door to thinking through all of the different components of system or systems that tend to involve punitive logics, institutions that rely on punishment or coercion as ways of controlling people's behaviors, institutions or agencies that are focused on surveilling individuals and communities, and also all of the industries that have been able to profit off of the incarceration of people and the criminalization of people in the United States. Finally, I think that it's really helpful when we're talking about criminal records that people have to acknowledge people convicted of, and then whatever offense we might be talking about, rather than labeling someone as a violent offender or a drug offender. I think when we are using person-first language, which is an intervention that I think spans well beyond the scope of this talk, we're able to sort of put a person and their humanity first rather than thinking about their conviction or the worst day that they may have encountered the criminal legal system. Similarly, person on parole or person on probation is a more helpful way of framing things than parolee or probationer, because again, we're trying to acknowledge people's humanity first. We're also recognizing that person on parole or person on probation acknowledges the ways in which this is a temporary state of being. And there's a number of circumstances that have contributed to the reasons why the state is supervising and mandating and controlling aspects of someone's life. So when we talk about criminal legal involvement, I like to think about this phrase, criminal legal involvement, in very broad terms. When I use it, I'm talking about arrests. I'm also talking about other forms of police contact like traffic stops, or in New York City, stop and frisk for many years. I'm also talking about misdemeanor and felony cases that someone might have in criminal court. I'm talking about jail time or prison time that someone might be serving. I'm also talking about probation, parole, pretrial supervision, diversion programming, and also involvement with the family policing system, otherwise known as the child welfare system. So it's very well documented that involvement with the criminal legal state apparatus and all of the many sort of manifestations of the criminal legal system has tangible effects on the health and well-being of individuals and families. So I think it's really helpful when we're thinking about criminal legal involvement to think as expansively as possible about the ways that this might be having effects on the health of our patients and our patients' communities and families. So I think as a mental health practitioner, I like to start or ground some of my talks with a little bit of information about the really vast disparities related to mental health in particular within the criminal legal system. So we can see here that according to the federal government, 44% of incarcerated adults in the US have a mental health diagnosis. This is compared to about 22.8% of adults in the US population at large. We can also see that of those who have been given a mental health diagnosis by the criminal legal system, especially among older adults, only 18% of those older adults who are incarcerated are prescribed medication to treat their mental health conditions. So I think what these statistics illustrate to me is that there's both a disparity in terms of access to treatment, access to medication, but also even access to potentially like therapy or diagnoses. And so I think it's valuable to think about the ways also in which someone may enter the carceral system without a mental health diagnosis, but due to stressors or strains or triggers within people's experiences with this system, mental health symptoms may emerge over time. And I also want to emphasize the effect of incarceration and criminal legal system involvement on physical health. I think we have a number of studies documenting the very high rates of a lot of chronic health conditions for people of all genders who are incarcerated in the US. Very disproportionate rates of hypertension, asthma, multiple kinds of cancers, also arthritis. We also know that prisons and jails are sites where infectious diseases often spread quite rapidly. We have the COVID-19 pandemic as an example of that, but also tuberculosis, hepatitis C, and HIV rates are generally much higher compared to the general population. I think really importantly for all of us who are community-based or hospital-based providers, it's really important to recognize the ways in which the post-release period from prison, but also from jail, is a particularly high-risk period. There's multiple studies that have shown that the risk of death spikes in the post-release period, and this is the risk of death by a number of different means, including death by suicide, death by homicide, or death as the result of violence, drug overdose, again, cancer-related death, and also cardiovascular disease-related death. And so I think as we sort of hold in mind a lot of the disparities that I've talked through, it's valuable to think about the points of intervention that we can make, and also the points of intersection or overlap between the criminal legal system and healthcare systems that we might be working within. And when I'm talking about this, I'm thinking about correctional healthcare, community mental health clinics, and hospitals. And I want to frame this through the sequential intercept model, which is this helpful model created by two researchers, Muñez and Griffin, in 2006. So this is a graphic of what the sequential intercept model is. You can see here that we have 5 different intercepts, and they're sort of bookended by community on both ends. And you'll see here that there are multiple points of contact that an individual might have with the criminal legal system, and also this generally refers to the mental and behavioral health care systems that are based in the community and also based in incarceration facilities. So I think the easiest way of explaining how this model is generally applied is to think about all of these different points of opportunity for someone to intervene and ideally remove someone from the trajectory of criminalization or the trajectory of incarceration that often results from a number of interventions at the community level. So I think it's a really valuable tool for mapping out the kinds of system involvement that our patients and clients also may have experienced before presenting at our hospitals or our clinics. There are all of these different points of contact with these very massive systems. Often folks find themselves moving, you'll see sort of bi-directional relationships in some of these sort of points of interception. And I think it's valuable for us to position ourselves often within the sort of crisis care continuum, thinking about the ways in which we are relating to systems like 911, local law enforcement, but also the ways that we're relating to other aspects or components of the criminal legal system at other intercepts. And with that in mind, I think it's really valuable to highlight 3 intercepts in particular. First, we can see intercept 0 is where crisis response or emergency or urgent care is provided. This is an intercept where police are often involved in transporting people to care or checking on people in their places of residence. This is obviously a site where the risk of harm or the risk of injury or the risk of death is increased with police involvement. We can also think about the third intercept as a critical point at which the criminal legal system and healthcare systems are often interacting. Intercept 3 is where a lot of diversion happens after someone's been arrested and charged. Intercept 3 encompasses standard and specialized problem-solving courts. This includes mental health courts and drug treatment courts, as well as diversion programs. And what we see at this intercept is a lot of treatment mandates. So it's really valuable to understand as a community-based provider the ways in which a patient of yours may or may not have information that they need to be shared with the court as a monitoring body. Also, you'll notice that I've sort of highlighted jail in this intercept as well. I think it's valuable to think about the ways that jails and prisons have healthcare providers within them. And those healthcare providers, even if someone has limited access to them, may also be a valuable source of information for those of us who are community-based to understand the kind of treatment or the kind of diagnosing that happened for an individual while they were incarcerated. And then finally, I want to think a little bit about intercept 4 and spend a little bit of time on this intercept in particular with us today, thinking about the reentry stage as this really critical period in which the transition from jail or prison to community is happening. This is also a period sometimes where people are being supervised by the state, whether that be parole or probation, or if someone's released from jail, it may also be pretrial services, of which there are many in New York City. So this is a period of time in which someone really often is in need of a lot of support relinking to benefits, to health insurance, to healthcare providers, and also to social supports. I think that this is a period following a major life disruption in which someone's been incarcerated, isolated from resources, bridging the gap and getting folks connected back to the services that they need in order to transition successfully is really important for us to be thinking about as community practitioners. So often when we're talking about this fourth intercept, thinking about reentry, there isn't really a distinction that gets made between jail versus prison. But as someone who researches this and someone who has a lot of experience, both from teaching experiences in prison and jail, but also collaboration with different systems when I was working in public defense, it's really important to make the distinction and to think about the different actors' needs and resources involved in jail versus prison reentry. So I made this table partially as a way to help folks understand the distinction between jail and prison first, but also as an opportunity to think specifically about, in New York City and New York State, the different parties or actors that are involved in some of these different contexts. So jail generally is a period following someone's arrest. We think about it often as pretrial detention. So this is prior to a conviction, prior to someone's guilty plea. If they're being detained, it's often in a jail. There are county jails in upstate counties in New York State, and the predominant jail in New York City is Rikers Island. When I was practicing in New York, there were also borough-based jails, but I believe most of those have closed. And I know that there is a plan to close Rikers, but I feel that it's kind of been stalled out by the current administration in New York City. I think it's really relevant to think about the different actors who are involved in this jail stage as being not just the Department of Corrections, but also New York City Health and Hospitals, the public hospital system in New York, because they're the ones who provide correctional health services. So there's a division within the public hospital system in New York City called Correctional Health Services, and they're the doctors, nurses, social workers, psychologists providing care to individuals within the jails. One of the big challenges in jail incarceration, obviously, is that there's minimal access to mental health services or discharge planning. What we also know is that for most individuals, it's very challenging to plan at all for release from jail because there's often not a set release date for someone. someone might be serving a misdemeanor sentence, and then they'll be given a concrete set sentence that they're serving. But often for folks who are incarcerated pre-trial, your bail status might change. Someone might pay your bail. A judge may lower your bail. Or you might be released into a diversion program. And all of these things tend to happen quite abruptly. You're often released without a lot of advance notice. And as a result, this makes it really difficult to plan for things like follow-up appointments or prescriptions that someone might need afterward. Your Medicaid coverage may have been disrupted since Medicaid is suspended or shut off when someone is incarcerated in a jail or a prison. And so New York City has a number of resources for individuals who are leaving jails, but often individuals who are leaving jail are unaware of what those resources are or how to access them, which brings us into the jail reentry phase of this table. So we think about jail reentry as being reentry often back into the community in which someone was arrested, right? So in New York City, if you're arrested, you will probably be sent to Rikers Island. After you're released from Rikers Island, you may return to the same borough or neighborhood or community that you were in. You may also not have a place to return to because employment and housing may have been disrupted. So often the actors who were involved in this stage are, again, New York City Health and Hospitals. They've actually built out a clinic system and a hotline system in recent years to try to do a better job of bridging folks who received correctional health care to a lot of the resources available in the community. New York City Human Resources Administration administers all of the benefits that folks in New York City have or don't have access to. And so reconnecting with them is really vital if someone's been receiving SNAP benefits or cash assistance. HRA in New York also is responsible for reactivating Medicaid. And then there are also a number of projects designed essentially to help link people to care through the New York City Department of Health and Mental Hygiene. So I've already mentioned this a little bit, but really want to emphasize the ways in which this is a critical period for folks, especially if they've dealt with a sort of abrupt arrest. There's a high likelihood that there's been a disruption in whatever services or healthcare or benefits they were accessing before. And in some cases, for individuals who are serving probation time or who are being diverted and being monitored by a diversion program or pretrial services, there's a huge risk of violation of the terms of someone's release during this time period. Often this happens because someone has inconsistent access to a phone, and so there's not an easy way for them to check in with individuals who are supposed to be following up with them from the state. Because housing and employment have been disrupted as the result of arrest and jail incarceration, we also see what I've sort of deemed a jail to shelter pipeline, in which the New York City shelter system plays a large role in most individuals' jail reentry if they've, for example, lost housing as a result of being incarcerated in jail. So that's jail. Jail generally is what I sort of like to think about as sort of a hyper-local context of incarceration. Most of the time, people who are incarcerated in jails are incarcerated relatively proximate to where they were living or staying before jail. But I want to shift to talk a little bit about prison, because I think that prison is, due to mass incarceration, an experience that our patients and clients are also coming back with. Prison happens for individuals after a trial or after a guilty plea. And so the reason that someone would end up in prison is because they've been convicted of a crime or because they've pled guilty to a crime. I want to be really clear that I think it's also important to not say someone is guilty of a crime, because we know that the way that the criminal legal system is set up relies on plea negotiations that often ask someone to plead guilty to an offense that maybe they haven't actually committed. And so in the context of New York State, the New York State Department of Corrections and Community Supervision operates the correctional facilities, all except one of which are several hours upstate from New York City. And so when I'm thinking about prison incarceration, I'm always thinking about the ways in which someone is sort of forcibly separated from their family, friends, support systems that are local often in New York City. Also the ways in which someone's care is disrupted in a more massive way. Generally, prison terms are at least a year long. And so this is a substantial amount of time for someone to be away from the resources and relationships that they may have been cultivating in New York City. I think that there's also a huge phenomenon worth paying attention to as providers, institutionalization, which really refers to the ways in which an extended period of time being incarcerated in a prison obviously has long-lasting mental health and emotional health effects. We think about the ways in which someone acclimates to a really sort of odd schedule where your day is planned for you by the prison. Often you wake up before dawn. If you are managing court dates or visits, those are things that are managed for you. You don't have control over those things. And you're also exposed to a high degree of trauma and violence. I think it's really important to think about the ways in which we often describe safety and community violence as being things that we want to work on. We don't often think about the ways that prison itself is violent and the ways in which someone's experiences in prison are often traumatogenic with long-lasting effects well after they're released from prison. So this brings us into talking a little bit about prison reentry. And again, the New York State Department of Corrections and Community Supervision, including parole, and the parole board in New York State are involved often in individuals' experiences here. Reconnecting with the Human Resources Administration in New York City and the New York City Department of Health and Mental Hygiene are often processes that are initiated when someone is leaving prison. I think there's a bit of a trade-off here when we think about transitioning from jail versus transitioning from prison. In the context of transitioning from jail, we see a lot of individuals who don't have a date that they're prepping for, which means that things are relatively abrupt and hard to plan for. But in the context of prison reentry, what we often see is individuals who are coming back with a felony on their criminal record, individuals whose Medicaid has most definitely been shut off and needs to be reactivated. I think due to the fact that people are in prison for longer than they're in jail, generally speaking, there's also a higher degree of disruption to the social supports or important relationships in their lives that may have existed prior to their prison incarceration. And for a number, or I would say the majority of individuals returning from prison, most are on parole for some amount of time. And parole or post-release supervision is a time period in which parole officers are often mandating individuals to complete follow-up evaluations and appointments, search for housing and employment, and also, readjust simultaneously to all of the ways of life that are now once again in your control or your responsibility that were previously controlled by an institution for you. So I think prison reentry in a lot of ways has different challenges than jail reentry. And I think being specific about the differences between those two processes is really important as providers because there are a number of different needs. There's overlaps, but I would say a lot of really important distinct needs to be attuned to as providers. So here I want to think about reentry a little bit more in depth, and I want to encourage us to think about reentry as a verb. This is a quote from C.J. Smiley, who is a professor at Hunter College of Sociology. He's written an amazing book called Purgatory Citizenship, which is thinking about the reentry process. And in an article that he published online, he said that reentry is an extension of, not a termination of, the carceral continuum, which exacerbates surveillance, punishment, and restrictions, creating a purgatory citizenship that places individuals in a precarious state of limbo somewhere between confinement and freedom. So I think even in the sequential intercept model that I've introduced, we've talked about reentry as a stage or a moment in an individual's process where their incarceration ends, they're reintegrating. When we talk about reentry as a noun, I think we miss out on an opportunity to think about reentry as something that patients and clients do, but also as something that is done to them by the systems that have incarcerated and criminalized them. I think there's a large industry that's really proliferated, mostly in the past 2 decades, of reentry service providers. Those often include job training programs, healthcare providers, and housing providers. And we see that in the expansion of mass incarceration, there's also been an expansion of post-release supervision or parole supervision. And what this means is that reentry is this, again, critical time period where individuals who are trying to reconnect to a number of resources in the community are also at a very high risk of death, as I mentioned earlier, and at a risk of reincarceration for parole violations. And so we think about parole violations as being triggered by a number of different things. One being rearrest, obviously, but also parole violations can be issued for missed parole appointments, missed phone calls with a parole officer. A parole officer may drop into the address that you've provided them, and if you're not there, that counts as a violation. Non-adherence to mandated evaluations or treatment, or also failed drug tests. And so I think it's really important for us to think about the sort of mental and emotional experience of living under the threat of reincarceration, right? That alone is a giant stressor. But in addition to that stressor, trying to reassemble your housing, your employment, your crucial support networks when maybe you didn't have those before you were incarcerated, on top of this threat of reincarceration, is something that's really, really important to be attuned to as a trigger for a number of chronic physical and mental health conditions worsening. So how does all of this impact our ability to build rapport with patients? I think I've really tried to isolate some of the sort of key themes that have come up in my work and that I've really learned from patients that I've worked with. And I want to just walk through those relatively quickly to give folks an opportunity to think about how these are showing up in the context that you're practicing in. So first and foremost, the role of trust and confidentiality is really central here. When individuals enter into treatment or seek care, probation and parole officers might want to follow up with us as treatment providers. And it's really important to think about informed consent as something really crucial to be talking about and thinking about from the beginning of a treatment relationship. So obtain informed consent from a client about the nature and degree of detail that you share information about treatment with probation and parole is a really vital opportunity to build trust and rapport and a working alliance that in some way gives some agency back to individuals who have had that agency removed by a punitive system. I think this is really vital also because of the relationship that we as providers might have to authority. It's been really helpful for me to remember that even when probation or parole or a child welfare agent is interested in the details of a client of mine's treatment, maybe I've had a conversation with that client or patient where they've only authorized for me to share the dates of treatment that they attended, requesting that they want their diagnosis to be kept private or the content of the sessions to be kept private as well. And so I think remembering that the same rules regarding HIPAA apply here, even if probation or parole officers might make you feel pressured to offer more information, having the same kind of relationship to disclosing patient health information that you would have in other contexts, even when you're engaging with representatives of the state, is really important. We're also thinking about the degree of ambiguity and uncertainty in patients' lives when they're approaching healthcare encounters. So they may be dealing with precarity that comes from being under post-release supervision or having an open court case. They may also be reintegrating after experiencing losses while incarcerated. And so being reliable and consistent in the way that we show up for patients is a really important role that we can play as providers for offering some consistency in a holding environment when a lot of other aspects of our patients' lives might be up in the air. Relatedly, I think it's just important to acknowledge that the whole criminal legal system is traumatogenic. So even as the system treats our patients as perpetrators, there are a number of ways in which patients have been victimized that we may or may not know. And so being attuned to mistrust or hesitation to engage, especially when there's maybe a mandate to treatment, is important in terms of the way that we listen for experiences of trauma and loss. And finally, I think it's really important for us to have a systems literate perspective as a means of alleviating stress for patients who are system impacted. So our lack of systems literacy often translates into a frustrating encounter for our clients or patients. If a client has to explain to us the difference between probation and parole or the difference between jail and prison, that's time taken away from us being able to hear about their needs and what they are hoping to get out of their encounters with us. And so building rapport through an awareness of how these systems work is a really key way, I think, to be able to collaborate more effectively with the patients and clients that we see who are impacted by these systems. So obviously, given the wide-ranging effects of the criminal legal system on the lives of many of our patients, I'm also advocating for us to think about abolition more seriously. I'm using the geographer Ruth Wilson Gilmore's framing of abolition here. She says, abolition is about presence, not absence. It's about building life-affirming institutions. You'll see here, just very quickly, a graphic from an amazing policy think tank called Interrupting Criminalization that also runs a lot of provider support spaces. This graphic really demonstrates that a big component of the prison industrial complex is the state itself. So we see that punishment for social problems gets delivered by the state in the form of incarceration, aggressive policing, family policing, and through social welfare and healthcare providing agencies. So I would invite us to think about moments where provision of healthcare is conditioned on a particular kind of behavior, where our clinic or hospital policies are in some way policing patients' behaviors or punishing them for non-adherence to treatment, as ways in which these carceral logics show up in a number of different contexts, well beyond the scope of just jails or prisons. And so these are all reasons why in October 2020, the American Public Health Association actually recommended moving toward the abolition of carceral systems and building in their stead just and equitable structures that advance the public's health by, both during and after the COVID-19 crisis, 1, urgently reducing the incarcerated population, 2, divesting from carceral systems and investing in the societal determinants of health, including housing and employment, 3, committing to non-carceral measures for accountability, safety, and well-being, 4, restoring voting rights to formerly and currently incarcerated people, and 5, funding research to evaluate policy determinants of exposure to the carceral system and proposed alternatives. So again, this is straight from the American Public Health Association's policy brief. And so in service of the APHA recommendations, I want to offer some specific sites of inquiry for folks to pursue on your own. These are questions to reflect on, prompts to try to encourage collaboration with criminalized clients over whatever institutional imperatives there are to manage risk or threat. So the first domain that I'm thinking about is mandated reporting. And I'd invite you to think about how mandated reporting shows up in your work. Are there collaborative or client responsive ways to build safety and assess or manage risk that don't involve the punitive state? I've also linked underneath all of these as well, and I'm happy to share slides afterward if anyone would like these links. Secondly, I think about collaboration with law enforcement, thinking about how your workplace collaborates with law enforcement, and thinking about when and why security officers and police are involved in patient experiences. Then thinking about confidentiality again, when obtaining consent to share treatment information with the state agency, what does the conversation look like with your patient or client? And then finally, thinking more about involuntary hospitalization. So being really curious about the ways that practices of involuntary hospitalization punish someone for being in crisis potentially, right? And again, these are maybe not experiences we're enacting, but also I think experiences that in a lot of ways, clients might be coming into our healthcare providing context with those experiences in the front of their minds. So I'd invite us to think really specifically and really concretely about where carceral and punitive logic show up in your own work and also how you can work on undoing them. For those of us who are working in clinics, how do we treat clients who we perceive to be high risk? And how are our calculations of risk informed by stereotypes, assumptions, or presumed system involvement? Which policies are enforced and on whom? Are there demographic patterns in terms of who's removed from caseloads? How are crises managed? Are police involved in that crisis management? And are there other policies, practices, or norms that contribute to a punishment-oriented approach to work in clinical contexts? And so for folks who are based in New York City, I wanted to highlight a few resources that might be valuable to connect patients to. First, if your patient has been incarcerated at Rikers Island or any of the city jails, the Port Line is a somewhat new initiative run by Correctional Health Services out of New York City Health and Hospitals. They've designed it to essentially be a one-stop shop for recently released individuals to both call whenever or do walk-in appointments. And you can see here that there's, all of these different reasons someone might call, getting plugged into services, getting medication, including Suboxone, getting linkages to other mental or physical health care, information about benefits, information about housing and eviction prevention, and also just answering questions about the care that you got in jail. The Portline clinics have access to correctional health services records. And so in terms of continuity of care, really valuable to reach out to them also as a means of connecting with correctional health services providers. EAC CRAN, or the EAC network, is another resource for bridging recently released clients with a Medicaid grant card to cover the cost of psychotropic medications and accessing bridge scripts for that medication. They're also helpful in terms of reactivating Medicaid and helping clients navigate the HRA system in New York. The New York City Department of Health and Mental Hygiene is another resource for connecting clients to ongoing care. And then finally, I've listed a number of nonprofit organizations and associations that provide clinical services and other supports to individuals who are currently or formerly impacted by the criminal legal system. So you'll see the Fortune Society, Women's Prison Association, the Center for Community Alternatives, the Center for Justice Innovation, and the Osborne Association. These are all resources that have been helpful to former clients of mine. But again, similar to my caveat about language, I think it's really valuable to ask your clients directly about what experiences they've had with different reentry providers or community-based organizations and resources before making any assumptions about where to refer folks. This page has a number of additional resources for anyone interested in learning more about the criminal legal system, the role that healthcare and public health practitioners can play in advancing anti-carceral solutions, and also the strategies we use in everyday clinical practice to support our criminalized patients. So at the bottom of this page is a QR code that links to this page if you're hoping to have access to any of these links. Most of them have pretty much informed the perspectives that I'm sharing in a lot of the slides prior to this. And so definitely helpful to take time and do some additional learning or deep dives if that's of interest to you. And as promised, I wanted to leave time for Q&A. So I haven't been monitoring the chat or the Q&A, but I will lean on you, Naomi, for any questions that have come up.
All right. So first, thank you so much, Brianna. This is an amazing talk. I learned so much. It's such an important topic, and I think relevant for a lot of our work here. So I'll start with just questions in the Q&A, and then there's one question in the chat. So okay, so a question from Jacqueline. Any advice for how to build rapport? And you may have answered this, but any advice for how to build rapport with patients impacted by the carceral system, especially when they're accompanied by multiple correctional officers in the room? You're on mute.
That's a great question. So I think one of the things that has been really sort of instrumental for me in terms of both like jail-based and also post-jail-based interactions with clients is like the value of also acknowledging that presence directly with clients or patients. I think in terms of building rapport with incarcerated patients, when there are correctional officers in the room, for me is really sort of a contextual or like moment by moment kind of decision. But I would really, really encourage folks to think about like whether it's appropriate in some circumstances to acknowledge the correctional officers directly and acknowledge with a patient or client that, you know, we're not the only two people in the room, and I know that that might change what you share with me. I want you to know that like I am hoping to preserve confidentiality, but I know that the dynamic is maybe different because we're not in a setting where it's just the two of us. So one thing that I think is just important is acknowledging that. I also think we don't always know what the kinds of relationships are between correctional officers and individuals who we might be treating. And so it's really important, I think, to not assume that there might be a hostile relationship between correctional officers and clients, even though I think there often is. But being really strategic about, first and foremost, just acknowledging the sort of strangeness of the situation, that maybe we've all been trained to do one-on-one clinical work, but all of a sudden there's this intrusion from a system. And that does, unfortunately, limit the way in which we're able to engage and also gather information or assess with individuals. So I think it's sort of an impossible question in some ways. I think my preferred answer would be like getting correctional officers out of that context, but I know that's often not possible for us as clinicians.
Thank you. So another question from Jacqueline is, I have a patient who expressed feelings of depression. He is currently incarcerated in a prison. How do you recommend I assess and connect him to some mental health resources through the New York State Department of Corrections? So I know you mentioned a bunch of resources. So maybe you can talk a little bit more about like how to assess for mental health with someone who's currently in prison or jail, and maybe more generally, like how do anyone completing like an intake across a psychiatric setting, a medical setting, how do we ask these questions in a trauma-informed lens?
That's a great question. So I would say in terms of the New York State Department of Corrections and the prison system, generally speaking, most prisons in the state will have like their own sort of mental health providers. I'm actually not sure in New York State. I know more about the process in Illinois now, but I'm pretty sure that the process in New York State would involve trying to contact the prison directly. But generally speaking, in jails and in prisons, there's something called sick call. And so what that basically is often sort of like a clipboard that someone would sign up to see clinical staff. And so I think in the context of someone who's currently incarcerated, encouraging them to do that and to try to get seen at a clinic on site is really important. I think there's often a lot of stigma around putting yourself on sick call for mental health in particular. But in this case, if you have a patient who's experienced these feelings, trying to get them on sick call might be the fastest way. And beyond that, then trying to contact the facility that they're in directly to flag this for their clinical staff is, I would say, the next step. I think generally speaking, when we're assessing or working with clients or patients who have any sort of system contact, it's really important to first and foremost ask the questions using language that's not stigmatizing. So not asking, are you a felon? But instead asking, like, what are your experiences with police? Have you had police contact? Have you had contact with the criminal court system? Asking questions in terms of systems contact that people might have opens the door for them to define that in a number of ways, and also opens the door for them to say, I haven't personally experienced this, but my family members have experienced this. So yeah, I think that's, maybe the shortest answer I can give with the limited time we have.
Great, thanks. So a few more questions. Do you have any resources related to working with adolescents who've had carceral experience, especially adolescents in juvenile detention or suspension arrest in school contexts? And any resources you can recommend?
Yeah, for sure. So I think something that, if I'm remembering correctly, is true in New York City is that, and I think this is true in most cities now, a lot of individuals who are under the age of 18 and or 19 most of the time are held in juvenile detention facilities that are often run by like child welfare system providers. So that's run through a separate agency in the city. It's not run directly through the Department of Corrections. So you're dealing with folks who are a part of the I would say carceral system, but through a child welfare lens.
Is that Children's Services?
Yes. So it would be ACS in New York. The Administration for Children's Services operates, I believe, Horizons and possibly one other facility. And so I think being able to sort of deftly navigate through that system is it could be its own talk, obviously. But I would say thinking about, off the top of my head, the PD Green program, PD like green, would be a starting point. I know that they're a program that often works with folks in and coming out of Horizons. But I also know that, there's a huge amount of literature on all of the ways in which like experiences and early contact with juvenile detention often translates into increased involvement for individuals later in their lives. So I think the Department of Education is another really important city agency to be involved with in the context of someone's experiences of schooling. Individuals are supposed to receive access to essentially alternative high school classes while they're in Horizons. But I know that access to education is also disrupted pretty frequently due to things like COVID and also violence in those settings.
Okay. So thank you so much. We're actually out of time. I want to be respectful of everyone's time. There's a lot more questions. And if it's okay, I'm happy to share them with you, Brianna, and you can maybe answer them. via email. I'm happy to share. So anyone who's interested can reach out to me and I'll share those responses and more of those resources. And this is going to be recorded and put on the Just Talks page. So you're welcome to review it and have access to those links and resources. And thank you so much. This is so important. This is so necessary. And I think a lot of us have a lot more questions and just got us thinking. And that's really great. So thank you so much, Brianna. Thank you so much, everyone, for attending. And the slides, people are asking if it's okay for you to share the slides. So again, this is recorded and can be viewed later on, but if you're open to share slides,
absolutely.
we're happy
I would say, yeah, folks are welcome to also email me directly or reach out on Twitter. I'm happy to follow up with folks and share slides or, share more specific resources since I think I can hopefully do a little research outside of the context of the talk for anyone as well.
And then for anyone within the Sinai community and external, we just want, a few people are putting this resource in the chat. So I'm forgetting what it's, the Coming Home program is affiliated with the Institute for Advanced Medicine at Harlem Health Center, so near 124th Street, which is a comprehensive program that provides medical care, mental health, and social work services for those who have been formerly incarcerated. So that information is in the chat, and I'm happy to send it via email to anyone who wants it as well. So thank you for sharing those resources, everyone. Have a good day.
Thanks so much, everyone. Take care.